I'm not hungry. This is really weird. That was revelationary to me in my mind. It was like for the first time I had this sense of satiety that I'd never had heretofore. And that just,
Yeah.
it just put in my mind that, man, maybe some of this nutrition stuff isn't all that crystal clear like we thought it'd be. And I was like, wait a minute, we can actually impact these people's lives in a way where they don't need a surgery.
Dr. Shawn Baker, a former surgeon turned carnivore diet advocate. How did a top athlete and disciplined doctor end up ditching vegetables and questioning everything about mainstream nutrition?
Hi, everyone. Dr. Eric Westman here, and welcome to my channel where I typically review and debunk nutritional information online, but occasionally I have the great pleasure to interview the people who I think are the movers and shakers in the nutrition and keto and low carb carnivore worlds. And so when you look and talk carnivore, there's one name that comes up, one doctor, it's Dr. Shawn Baker. Welcome to the YouTube channel.
Before we dive into today's video, I want to personally invite you to join my free diabetes lab workshop. In this essential workshop, I'll walk you through how to understand your lab results so you can take control of your health and reverse type 2 diabetes and prediabetes for good. See the link in the description to sign up.
Hey, Eric, thanks for having me. Speaking of movers and shakers, you've been doing this for a heck of a lot longer than I have, and I certainly all respect to you for pioneering this sort of way of thought for, gosh, many, many decades now. So thanks for all you've done.
Well, you're welcome. You know, for my first part of my career, I was working with a brilliant PhD in the smoking cessation world, and my job was really to kind of keep him safe because you need to have all these great ideas. And now I feel like I'm trying to keep you all safe with all these crazy nutrition ideas. But yeah, we started studying. Started studying this 25 years ago, and you know, I got into this by patient care. Two of my patients did it in front of me. Why don't we start? Assume that someone doesn't know who you are, where you're from, what you do. How did you get involved in this? It started with your training, and then how did you get involved in being the kind of the carnivore lightning rod at the moment? And
Yeah, well, yeah, I mean, I was a conventionally trained physician, you know, my specialty was orthopedics. So I'd say, you know, I practiced, had a fairly, you know, sort of standard career for much of it. I mean, I spent some time in the military, did a bunch of kind of trauma surgery before I went into my own sort of private type practice. And, you know, it wasn't until I was probably in my early 40s where I took a greater interest in nutrition solely for personal reasons, because I just wasn't happy where I was health-wise. I've been an athlete my whole life. I'd always trained and exercise, and you know, since I was a teenage kid, I've been doing it, and I still do it. But you know, my health was just going in a direction I didn't like it. I was probably developing some level of metabolic disease. I was feeling my 40 some years of age at that time. As an aging athlete, you got a lot of mileage on you. And I didn't like that. And so I started playing with let me just go on a diet. Really the first time I'd ever thought about dieting in my life, because I'd always, you know, been able to compensate through exercise, and I ate a lot of protein, and I just didn't eat a bunch of junk. But so I made a concerted effort to really focus on diet. And I went on this, you know, basically a low fat, high fiber, vegetable heavy, lean protein diet. And I lost weight. I mean, I went from about, at the time I was walking around at about I'm a big guy. You've met me, Eric, you know, I'm a pretty big man. I was walking around at about 290 pounds at about 6'5", and I'd been there about 20 years as an athlete, and I needed to be that because I was competing in these strength sports. And so I dropped from that down to about 230 in a course of about 3 months. But it was, you know, exercise 3 times a day, severe caloric restriction, you know. I mean, the food was quote unquote healthy. It was, you know, chicken breast and salads, and I was jumping rope, a couple thousand jump ropes in the morning before I'd go to my work, go to the surgical practice. Then at lunch, if I had a clinic day, I'd run in and get a quick workout in over my lunch hour. And then at night, after I put my kids to bed, I'd do another couple thousand jump ropes. As you imagine, that's not sustainable, right? And so I was like kind of miserable. I was lean and I looked good, you know?
well, but so you said so much in there. So you trained as a physician. Did you go back to your medical training to figure out what then to do? I mean, or did you, like me, get very little nutrition training?
Well, I mean, yeah, I mean, the prevailing thought, and it still is today, is, it's all about calories in, calories out, and it's all about, if you look at the USDA recommendations, it's just basically, fill your plate with a lot of vegetables and grains and lean protein and minimize the fat. And I kind of did that. And I don't disagree that it can work. It's very hard to sustain. It's very hard to deal with constant hunger. And I mean, I remember the nurses like, gosh, Dr. Baker, we liked you so much better when you were fat. They kind of said playfully, because I was grouchy. I mean, I was just like, I was just hungry all the time. So then I said, well, I can't do this. I just can't maintain this. I'm a disciplined guy. But
I just have to editorialize just a little bit. And that is, you know, as physicians, we actually, we've gone through high school, we've gone through college, we've gone through medical school, sitting on the behinds in lectures, and you had to be in the OR learning how to not even itch your nose if you had a mask on. I mean, so can you imagine asking just everyone to do what you did? to be hungry all the time and to have to exercise so it's like you were already selected out to be able to do something really difficult, and you did it.
yeah, I mean, I don't lack for discipline, and I'm fine. I don't. It's obviously you prefer to be more comfortable in the long term, but so I did that, and then I discovered that I can't maintain this. There's no way I can do this for the rest of my life.
Even you.
Yeah, even a guy who's almost psychotically obsessed with performance and some of this, I just couldn't see that as being something sustainable for me.
So that I kind of just make the comparison and contrast to the average person who comes to the office.
Yeah, that's for sure.
Many of them haven't even finished high school, so I mean they couldn't sit in class, and to ask them to do what you did, what many doctors do, it's just not practical, right?
I 100% agree. I 100% agree, Eric. So from there, I discovered some of the low carb thought. I think I think the first book that I read was Gary's book, Gary Taubes' book, Good Calories, Bad Calories, and that
Yeah.
it just put in my mind that, man, maybe some of this nutrition stuff isn't all that crystal clear like we thought it'd been. It cast enough doubt in my mind about the whole, the value of nutrition science. It's not that there's no value there, but there's a lot of flaws within it. There's a lot of assumptions, and a lot of the associations are very, very weak. And so, so I at some point discovered the low carb stuff, the keto stuff. I did that. I remember when I went keto for the first time, I was super excited because in the first time in my life ever, and I was probably mid 40s at that time, I wasn't hungry. Because I was a guy that was used to putting down 6, 7, 8,000 calories a day as a big athlete. I would go to a restaurant, and I'm not exaggerating. I'd eat two appetizers, maybe 3 appetizers. I'd get a couple entrees. And then for dessert, because I couldn't decide between the red velvet cake and the cheesecake, I just get them both. Right. I mean, I just ate a lot of food because I was a big guy and always hungry. And then I just remember the first time going like, wow, I'm not hungry. This is really weird. That was revelationary to me in my mind. It was like for the first time I had this sense of satiety that I'd never had heretofore. So from there, and this is the interesting thing for me, I was still practicing orthopedics at the time, full time. And we had a situation where we just had a lot of obese patients that needed knee replacements, right? That's just what you see. That's what the population looks like typically. And unfortunately, these patients are at higher risk for complications. They had higher risk for blood clots and infections and, just poor overall rehab. And so as a local community of orthopedic surgeons, we all got together and said, hey, we got too many people that are struggling with this stuff. Let's all agree to not operate on people with a BMI over 35 unless we've done X, Y, and Z to get them to lose weight. And so we all agreed to that. So, so one person didn't just take all the people that were obese. And so, but they didn't give you any guidance. It was like, okay, get your patients to lose weight. Good luck. You know how that goes. And because I was doing a ketogenic diet at that time and had good success with hunger, I started proposing it to my patients. And, maybe 20, 25% of the people would take me up on it and actually do it. But the thing that really blew me away was that in that cohort, I would typically say, here, here's a diet, here, read these books, here, watch these videos, try this diet out. And it was, the people that would do it, often they would come back to me at the 2 week point because I would follow up in 2 weeks to see how things were going. How's your diet going? And very often they would say, doc, I know we're scheduled for a knee replacement, in 2 months, but my knee doesn't hurt anymore. And that was what I was like, wait a minute. Well, and I would say, well, you know what? If your knee doesn't hurt, there's really not a good indication to do surgery at the moment. So as long as you keep on your diet and working for you, you don't need surgery. That to me was a light switch moment for me. And then I got really excited because by that time I had done thousands of surgery. I'd done hundreds and hundreds of knee replacements, gazillions of knee scopes. And I was like, wait a minute, we can actually impact these people's lives in a way where they don't need a surgery. Because even as a surgeon who liked to operate on people, if it was me, I'd rather not have the surgery. I think most people feel that way. If I could avoid a surgery, hell yeah, I'd rather avoid it. So that's what kind of got me into this sort of place. And then from keto, I ran into this wacky group of people just eating only meat. They call themselves a zero carb group, zeroing in on health. And it just sounded so bizarre. What do you mean? Where's your vitamin C? Where's your fiber? Where's your phytonutrients? All that stuff. But I was already sort of, bought off on the low carb being beneficial and not terrified by, fat. I wasn't there anymore. And so I was enough to the point where I said, you know what, I'm just going to try it. This is 2016. So I tried it for 30 days and I was just like, I just feel great. I mean, even more so than I felt on keto, believe it or not. I mean, I just had my digestion was better. I just felt like I got a little less inflamed. I got a little stronger, which was cool as an athlete. And so I've been there since then. And I've kind of just been promoting this carnivore diet. I wrote, obviously wrote the book on that for the last, I guess now 8 years I've been doing this. And, this is I'm starting my 9th year of this stuff. It's been interesting. I tend to say, look, this is a therapeutic tool. I don't care if you want to get a tattoo and call yourself Carnivore Carl, that's up to you. But I mean, as far as from the physician side, and you probably see this as well, it has such dramatic therapeutic potential that we should at least be willing to discuss it with our patients. And if they want to do it for 3 months, 6 months, and it helps them significantly, good for them. And then you can figure out long-term what they want to do. Some people decide they want to do it long-term. Other people they incorporate a few other things back in there, and many of them are still fine with that. So that's kind of where I'm at right now.
So how did you get the idea that this might help other people too? I mean, I guess you learned it from a group that already was.
Well, yeah, I mean, I'd already seen people it was seeming to help. The only reason I tried is because I saw, it's like, no one wants to be the first guy to try something. Well, let me see how these guys are doing. So I'd known there's some people that were doing it, and they were making pretty, what appeared to be at the time, extraordinary claims. Oh, my depression got better, or, things we as physicians would kind of scoff at. Oh, what? You had a diet and your depression went away? Get out of here, dude. Or your arthritis got better. We would kind of ignore that. I can remember specifically years ago, I remember I had a lady coming in and telling me how Brett hurt her knees. And I started looking at her allergy list and she had 15 allergies. And you're one of these kind of wacky patients and everything. He's kind of, you kind of compartmentalize these patients as they're a little bit strange. I'm going to kind of take what they say with a grain of salt. When do you want to schedule your knee scope type of thing? But I'd heard enough people doing that. And so I was on social media at the time, on Twitter at the time. And I had not the account, not the size that I have now, but I had, a few thousand people that were following me. And, we were talking about it, kind of goofing around saying, oh yeah, I'm going to get scurvy or my heart's going to explode or something, blah, blah from that. And so I managed to convince, believe it or not, in 2017, I convinced 100 people to do it for 90 days. And we actually recorded the data. We call it, because we said, well, it's an N equals 1. It's not, it's good, it's cute, it's good for you, it's N equals 1. I said, well, let's call it N equals many. So many people, we got 100 people to do it for 90 days, and we tracked their data. Average person lost about 30 pounds. Their heart rate went down by 10 points. They lost 8 centimeters off their waist. And then everything's subjective, because we didn't have any money. Everything we could measure subjectively got better. Digestion, sleep, mood, libido, skin, whatever. All these things got better. And so that's, kind of where that started. And then I started collecting those. Yeah.
In that first 100, so 100 in a row or selected, what percent had success?
Almost all. I mean,
well, I know it's everyone.
Wasn't all of them. I mean, I didn't, it wasn't a formalized study. It was more of a survey.
So basically you do it, it works.
Right. Yeah.
Right. So now we compare it to studies where, the professor gets 300 people assembled together and people barely do it, or they try it. They teach a difficult way of doing it. That's what happened at Stanford. They didn't ever ask anyone who used it. And then, people fall off and they can't see, no one can do it. Well, no, if someone can do it, it pretty much works, right? So, so I see I guess you weren't thinking of carnivore as an elimination diet at that time. It was just healthy eating. You felt great and helped you be fit rather than a medical treatment.
Yeah, I mean, I think it was still emerging thought on this, and I think it's still. I mean, to be honest, I think it still is. We're still trying to figure out some of this stuff because we just don't. As you know, Eric, there's very little money for nutrition-based research when it comes to mitigation of disease. It's all drug, 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 drug. So it's a slow process to get funded, to get the studies done. But yeah, you're absolutely right. I mean, it's like, because the question I have, I mean, in my mind, there is zero doubt that this can help people with with lots of conditions. Now, the question is, does it help 80% of the people, 20% of the people? We don't know that yet. And that's where the next phase will be to start doing interventional trials. And, keto's got a fair bit of that already. So this makes sense.
We're following another grassroots area where people with type 1 diabetes, or the parents of people with type 1, are doing a similar low carb. And I see carnivore as another version of low carb,
For sure.
keto. It's and they had such great results. We surveyed their Facebook group, and it was published in the journal Pediatrics. And similarly, there was a carnivore group that got surveyed and published in a paper. But the rebuttal that came back from someone I knew, someone in academia, said, well, those were exceptional people. Those were exceptional families and exceptional children, and no one really can do that. And I don't really agree with that. In fact, I'm thinking now that it's kind of almost malpractice to not offer some kind of dietary change, because the arrogance to assume that someone can't do it, well, of course, if you teach it in a difficult way. So carnivore has the easy idea of what to eat. So it takes away the worry about making complicated meals, although you can, and make it delicious. But I wonder if the adherence. So let's say you've gone from one you to 100, and now even on my YouTube videos that I do, I have to assume that these aren't people lying, and yet there's with benefits, right, of not eating vegetables, and but there's a difference between these internet anecdotes and a carefully assembled clinical trial. You're vetting out, making sure someone actually had that experience. Even with the type 1 Facebook survey we did, we verified the blood tests that people self-reported to be sure, talk to the doctors and got the clinic verification. But, I guess, as this grassroots, so people are not eating vegetables, and there's a lot of preclinical reason why that would work. And I certainly seen diabetes reversal and all these medical problems go away. What's the next step to formulate, what percent will have benefit, and how do you teach it so that most people will be able to do it? And I followed, and in fact was an initial investor in your company that teaches this. What have you learned from now, in the trenches, implementing this with people?
Yeah, let me just one comment. When we're talking about the ability to sustain or actually do this. I mean, I remember an interaction I had with another physician that says, I don't want to fight my biological urge to eat a cookie. And I'm like, that's not a real, cookies never existed. I mean, if you look from cookies don't even exist. So that's obviously not a biological necessity by any means. But as far as, as you probably are aware now, thankfully, and I've been talking about this for a long time, and I know you have to some degree, Eric, but we always saw low carb and ketogenic diets as weight loss diets and maybe diabetes management. But there is so much more which it impacts: mental health, inflammatory conditions, autoimmune conditions. So I see this every day. So now we're getting more and more people saying, hey, look, not only is it not just a weight loss diet, And there's a lot of ways you can lose weight. I mean, you and I would both concede there's lots of ways you can lose weight, but some of these things uniquely seem to have additional benefits with regard to, some of these other conditions. And so now,
Well, some are easier than others. Like you white knuckled through low calorie exercise.
right,
And,
right.
you know,
Yeah. I mean, it's a lot easier when you don't have to rely on discipline, and you can
you're not hungry.
rely on your physiology a little bit. Makes it a lot easier for sure.
And is that so? The appetite going away is something we don't talk about a whole lot. We kind of just assume that people know. There are a lot of people who don't know that, right? They're watching this for the first time. They're thinking this is kind of crazy, but the fundamental difference once you start fat burning, your hunger goes away. And in that group of 100 people with results, I'll bet that was universal.
Yeah, I don't remember specifically that particular asking about satiety, but I've seen this is one of the more common things I see is people that talk about cravings and addictions. They'll say, for the first time I ever found the off switch. I remember talking to a gal who was 800 pounds, everything. She couldn't stop eating cookies and candies and sweets. I went carnivore, lost 500 pounds in 2 years. She said, I found the off switch for the first time in my life. And she's somebody that failed gastric banding procedures and things like that. So, yeah, I mean, of course, now with the new GLP-1 drugs, people are more in tune with satiety, and these drugs act in many ways. But this is something that is,
You don't need a drug.
well, the same thing with, talking with, I'm sure you're familiar with Ted Naiman and Andreas Onfield and their HABA, where they're talking about satiety per calorie. And a carb diet that fits right in there perfectly. I mean, it's the perfect way to get satiated. Your point, though, your initial question was about how do you implement it? What have been early results? I mean, gosh, you've had so much experience in this. I just talk to people about, look, even if you're obese, whether you're obese or not, many people come to us malnourished in a way. And the definition of malnourishment is not necessarily underweight. It's just not the right amount of nutrition, the correct nutrition. And so they may be missing fat soluble vitamins or not enough protein or who knows, certain minerals that are low on. And so if you give them whole, unprocessed, very nutrient rich foods, a lot of times that helps them to meet those nutritional needs so they're not hungry all the time. And so I tell people, how much should I eat, Dr. Big? Well, eat enough so you don't want cupcakes or whatever the junk food is. And that's kind of their initial guidance. And you just tell them, you've got to eat enough to overcome those addictive behaviors. And that might take a few months. And then once you get there, then you can kind of play with macronutrient ratios and meal timing and meal sizes and portions. But it's a lot easier when you're not dealing with this psychological nightmare of addiction. I think that's the first step. I think when you're treating chronic disease, you are probably in many ways dealing with some sort of ultra processed food addiction. I think that's, if you don't realize that, you're going to be spinning your wheels. And so you've got to be prepared to do that. And this is, and you mentioned Rivera, our company. And so what we do is literally, we'll be in contact with patients on a daily basis as necessary, because some of them need it. Some people you can say, hey, go read this book and have at it. And some people do great, but there's a lot of people where they just need that handhold. And, there's some people that you got to just keep answering questions and reassuring them and remotivating them and, giving them the knowledge to continue to do that. And so we found that that's been very helpful. I think that's when I was practicing as an orthopedic surgeon, I was kind of waking up to this. Wait, nutrition's important. I had no resources. I mean, there's no one I could send them to. The best I could do is go watch this YouTube video. Here, go read this book or watch this YouTube video. I had no time to talk to these people. I mean, I was lucky to get 5 minutes to see my patients. I was in a busy orthopedic clinic. A 15-minute appointment would be a luxury. I usually have 15-minute appointments. I'd be double booked all the time. It's like, oh, okay, well, I got two of you guys in 15 minutes. And it's just like, I felt like I was on roller skates in my clinic all day. It was fun running back and forth. But it's not a good way to do medicine, as you know. I mean, you slow it down and say, what are we actually doing here? Let's heal the patient rather than healthcare has kind of devolved into this disease management, symptom whack-a-mole. And that's not what we sign up for as doctors. I mean, I'm sure you feel the same way, I would imagine.
Yeah, I at a VA, Veterans Affairs Clinic, learned evidence-based medicine and clinical trials and was frustrated and and not happy with the tools I had. We managed diseases, and I like to fix things. I'm a DIY kind of guy, you know. And now I love YouTube. I can just go and look, what tool do I need? How can I do it? So it wasn't rewarding for me as a doctor, as an internist. Now, as an orthopedic surgeon, you could just fix the knee, and people, you know.
That's one of the reasons I went into orthopedics, because I remember as a medical student rotating through my primary care specialties and watching how miserable the doctors were. They were complaining because the patients were never, oh, the patients are not compliant. They never get better. They were
Well,
beating their head. And I was like, orthopedics, somebody breaks their leg, I stick a metal rod on them and I'm done. Good.
but think about that. It's kind of a selection bias. So it's a fait accompli. It's it's kind of the depressed people go in and they can tolerate other depressed. So, the classic difference between internists and surgeons, you want to fix things, and a chance to cut, a chance to cure. And then we're just kind of, oh, well, I think the saying was, we're the last to get off a dying dog, the fleas, right? We're called fleas. And so that's the stereotype. But when nutrition is the key that we, neither of us really got in training. Even today, there's not much training about nutrition. So, but that could make us vulnerable to doing things that aren't healthy or aren't safe. I mean, so being in this world, watching people do the carnivore diet or versions of that, what have you learned for the safety limits of it? Are you worried about, you're on the edge of the cliff, someone's going to die, or are you, how far from the cliff are we?
Well, again, I've said this many, many times. There are many ways to get healthy. Carnivore is a tool in the toolbox that you should use when necessary. I think some people are more appropriate for others. It's simply for the point that many people don't need to do it. There's a lot of people that could just remove some ultra-processed garbage out of their diet and their health would dramatically improve. But there are certain people that, as crazy as it sounds, they're eating a clean diet, no ultra-processed food, no excess sugar. They're eating, some meat, some vegetables, some fruits, and they remove those things, the fruits and vegetables, and their health gets better. And I'm like, well, if it works, it works. Who am I to say that they're lying to me? And I've seen that, ad infinitum at this point, thousands upon thousands of people. And so I think, I know there are people within this carnivore space that are making these very hyperbolic sort of proclamations, and it's a panacea and it never fails. And I've seen people where it just doesn't work that well for them. I mean, I'm the first guy to admit that. What I also see, and I know one of the big topics that everybody talks about is, cardiovascular risk. Your cholesterol might go up. And I think we have a handle, thanks to guys like Dave Feldman, Nick Norwich, talking about lipid energy model, where you have to understand what the physiology is. If you get leaner and you rely more heavily on lipid trafficking to supply your energy needs, yeah, your lipid numbers are going to be up higher. And now we're seeing that maybe, I'm not the guy that's saying ignore cholesterol. I'm saying, let's get some more nuance here. Let's see what else is going on. Maybe get some imaging, periodic sequential imaging, see what's going on. And as you know, 5 years from now, that topic may be completely different. We either going to be saying, oh, we were all wrong, or you can ignore this in this situation. If X, Y, and Z are true, then LDL, the cholesterol becomes a non-issue. I don't know that we're there yet. I mean, it's still something that has to be proved.
I think the competing hypothesis is the metabolic syndrome. So high triglyceride, low HDL, abdominal circumference, blood sugar, blood pressure. And even then, in the recent studies of a lot of people looking at risk, the metabolic syndrome is much more associated with cardiovascular risk than LDL, cholesterol.
Sure.
So I focus on the glucose side of things, of course, and weight.
Yeah, I mean, I was Gerard Reaven who first described syndrome X or metabolic syndrome, did not include LDL cholesterol in his initial description. It was triglycerides, HDL, glucose, body fat, and hypertension. And so you're like, okay.
He wasn't respected and didn't get dominance in the medical world, right? It was the LDL cholesterol and the drug treatment. He kind of was marginalized. I met him and chatted with him before he died at Stanford, where he was. And, he kind of got mad at me when I said, well, you're saying exactly what Dr. Atkins is saying, because I knew Dr. Atkins before I met Dr. Reaven, and Dr. Reaven got all upset. No, I'm not saying the same thing. You can't eat all that fat. And so he still was in the old fear of fat paradigm, even though he knew about metabolic syndrome. But I love the name of one of his papers. It was, looking at the world through LDL colored glasses, as kind of a skeptical argument even years ago, just decades ago, that just to focus on that type of cholesterol was misguided. So now, okay, the discussion in my clinic is my ferritin's high and I'm going to get scurvy. I'm not getting any vitamin C, and how do I deal with this?
Well, I mean, I think the scurvy concern should be, I mean, obvious to people that have seen people that have been doing this stuff for years. No one gets scurvy. I mean, and I mean, scurvy is a bad thing. I mean, you die from scurvy. I mean, it's not like, oh, my gums got a little sore, I have scurvy. No, it's like, you got this particular rash and you've got blood in your joints and your skin's weeping open and you die. I mean, that's scurvy, and no one's getting that. And I mean, it's been known. I mean, literally.
Well, there's
Yeah.
one sketchy, I say not in a weird way, but more like it's just very sketchy anecdote of a guy who came out of the Virginia mountains down to the hospital every now and then and had scurvy. He said he was doing a carnivore diet. Anyway, so these kind of imperfect descriptions of what people do. Goodness knows what he's doing when he's away from the academic center. And then, of course, the worst thing is he said he was doing an Atkins diet. Well, what does that mean? What were they eating? Anyway, so the knee-jerk reaction is that,
Yeah, I mean, you might think there's a musician by the name of James Blunt who claimed in the 1990s, he was in college and he was supposedly diagnosed with scurvy, and his diet was like chicken and mayonnaise or something like that, which is kind of strange in itself. But I mean, and there was no like definitive proof. The doctor just said, well, maybe he got scurvy. I mean, it's like, because the doctor's probably never seen scurvy in his life and said, oh, well, we eat meat, you must have scurvy, right? Yeah.
A blood level was low or something. So I was listening to another carnivore pundit, Dr. Anthony Chaffee, and talked to him about it. And he quickly rolled off that, vitamin C is used to make hydroxyproline and collagen, and you're eating so much of it that you don't need the vitamin C to make it. And I thought, I'd never heard that before, but that's kind of brilliant reason why you don't need so much vitamin C, because you're consuming the thing that the vitamin C is helping you to make.
Yeah, there's a couple. Yeah, I mean, hydroxyproline, hydroxylysine go into collagen synthesis. And we do, believe it or not, I looked this up years ago, we do have actually transporters in our gut for those, they have these di-and-tripeptide transporters. And so you can actually directly absorb that, because some people say, no, it's going to be all broken down in the gut. It's actually absorbed intact. So we can do that. But probably more importantly, I think the biggest benefit that we see is vitamin C is involved in the function of carnitine. And carnitine has a role in lipid oxidation. And because, meat is very rich in carnitine. It's a really rich source of carnitine. So this is another sort of role that vitamin C would normally have, but it's being augmented by having meat. We know that vitamin C and glucose are very similar looking. They differ very minusculely when it comes to, if you look at them on a typical organic chemistry projection. I can't remember the name of the projection for it, but they look identical. They share the same co-transport, same transporter, so they competitively compete with each other. So if your glucose is higher, vitamin C absorption across certain membranes is going to be lower. So when you don't have a lot of glucose floating around, vitamin C is more utilized. Vitamin C, as we all know, is an antioxidant. Well, in low carb situations, often our antioxidants are upregulated, so we don't see as much. And even things like uric acid, which is also an antioxidant. Most people don't realize uric acid is an antioxidant. The red cell also has the capability to recycle vitamin C, which is something, and that capacity probably goes up. So the bottom line is the observations they made during the polar explorations, South and North Pole, 150 years ago, where sailors that had access to fresh meat did not get scurvy, or if they had scurvy, fresh meat would cure them. So, and when I mean fresh meat, it's just not meat that's been like stuck in a, dried or stuck in a can for 6 months, like the British sailors might have had. They were eating, hardtack, which is a bunch of carbohydrates, and dried meat, and they got scurvy because it wasn't fresh meat. So that's the difference.
Well, so we're tackling, so there are the guidelines of how much someone should consume. And of course, how much you should consume depends on what you eat, depends on how you're getting what metabolism you're fueling. So that trips up a lot of people. You know, the guidelines
Yeah, I
say,
mean, it's like the analogy would be, Eric, is if you want to recommend how much gas you need for your gas car, except your car burns diesel. You're like, well, it doesn't. It's apples to oranges, right? It's not the same thing. So we're, as carnivore keto people, we're probably running a diesel, and everybody else is running a gas engine or an electric,
well,
depending on.
but then when we check the fuel system or check the blood, which is taking around waste and fuel and all, the blood levels can be different compared to those who eat carbohydrates. So I see this in the keto carnivore world where the blood level something might be low, and a doctor says, therefore it's deficient. When no, the blood level isn't always a good marker of what's in the cell. And so now let's talk about ferritin just a little bit, because in some of the typically it's elevated, and then also A1C. They can be higher than the normal range that people get from the doctor of carb eaters, and it causes some concern. And other doctors can hold on to this as, see, you shouldn't be doing that, and yet I don't see clinical evidence of harm.
Right.
And so how about the A1C? In fact, there was an essay on your A1C. I think for a while it was a little elevated, and I used that as a reassurance to folks. Anyway, these are two other blood tests that seem off.
Yeah, I mean, I see a few. I mean, folate's often lowish, low normal. But again, what does a folate deficiency look like? Megaloblastic anemia. There may be mouse sores. Obviously with women, it's going to be neural tube defects. We don't see any of the clinical side of things, and so I think that's the important thing when people are looking at labs. As a physician, you're supposed to say, what is the clinical presentation? The first thing we learn about is to look at the patient, not just look at the labs. If you run to the labs first thing, you're missing the forest for the trees. And I think that's an important concept.
I mean, welcome to today's internal medicine world, where often the lab's the first thing people see, and then my patients get grief for having, a 10% elevation of LDL. I mean, so it varies, but that shouldn't be the way it is, of course. So what about the glucose A1C thing?
Well, I mean, as you know, I mean, hemoglobin A1C, and now that we have such ubiquitous usage of CGMs, we can see more and more examples of this. It's predicated on the assumption that a red blood cell lives for 90 days, and sometimes they live long. And a healthy person, they're going to live longer potentially, and that's going to give you more exposure to glucose over time. So if you're assuming you measure something that lasts for 90 days, but it's actually lasting for 115 days, it's not the same measurement. So a lot of people will come to me with like, hey, my A1C before I started carnivore was 5.2 and now it's 5.6. I'm really concerned. And I say, what? And if they have a CGM, what is your CGM? Well, it shows my blood glucose never goes above 94. I'm like, well, that's not, I mean, obviously people will say, well, you're measuring the extracellular fluid, you're not measuring blood. But I mean, the reality is, I think we're finding out a lot of things that we had sort of previously held as being.
Has anyone ever tested that hypothesis? So let's say take 10 people who are following a low-carb carnivore diet and have elevated A1Cs or even normal, test the red blood cell mass. As I recall, this is something you can do with a nuclear scan, because it's been so long since I did that in training. But you can actually measure this. And
Red cell life.
Before and after red blood cell life, not just the mass, but the red blood cell life. Has anyone done that yet?
I have not seen anybody do, because obviously it's kind of a selected research study. It's pretty expensive. It's my understanding. I mean, people look at a fructose. I've seen some fructosamines done. I've seen obviously the CGM comparisons. I've seen people look at retic counts. When the reticulocyte count is a high, that usually means a high turnover typically. So I mean,
I don't think it would be. That could be even like a PhD thesis, looking at red blood cell survival time. But another thought occurred to me. I like your impression, and that is the elevated blood glucose and diabetes is pretty much, and the consequences of amputations, kidney failure, heart disease, atherosclerosis, is associated with high carb eating, often 200, 300 grams of carbs a day, and the associated metabolism with carbohydrates. And I'm less concerned with a blood glucose elevation when people are not eating carbohydrates.
Yeah.
And
I mean, I got to,
metabolism.
yeah, I can expound upon that a little bit. If you go back way into like the 1920s, when they were first doing them, I think there was a study called The Metabolism of Eskimos. And what they found is the Eskimo blood glucose was running about 120. Their fasting blood glucose was running about 120 milligrams per deciliter, which we today would consider pre-diabetic, right?
Pre-diabetes, yeah.
But they zero evidence of kidney disease, diabetes, any diabetic retinopathy, any of that stuff. So I think you're right in the fact that it is conditional. The same thing as we touched on your earlier subject, talking about vitamin, like they did a study on Eskimos up in, I think, Greenland, or it might have been Labrador, one of the two places. And they were looking at two groups that had vitamin D levels. Both had low vitamin D levels, serum, because it was, there's no sun up there. But one group got rickets and one group didn't. Rickets is a vitamin D deficiency that shows up in kids with malformed bones. The group that got the rickets were eating a westernized diet with flour and sugar and canned goods. The group that still had low vitamin D but didn't get rickets was just eating their standard regular diet of seal and whale blubber and caribou meat. So again, even the serum levels don't necessarily, and as to your point, is an elevated blood glucose in a carbohydrate-free metabolism the same thing as something else? If you look at like the physiology of like cats and dolphins, both of carnivorous animals, both of them typically run higher blood glucoses, but they don't normally have diabetes, right? At least as we would consider, they don't get any of their manifestations. And again, at the end of the day, we're not treating a blood marker, we're treating the effects of that. The same thing, LDL could be higher, folate could be lower, but a T3 thyroid could be lower, and you're completely asymptomatic. So again, I think we have to reframe what does physiology mean and what the respective norms are. And we haven't, at this point, we're just speculating on this.
Of course, to really answer that question, you follow 1,000 people who are following a low carb, keto, low carnivore diet. You follow them over 20 years, see if they have diabetes. No one's going to do that study, but you could take a smaller number of people and see some of the short-term effects of higher blood glucose that's typically associated with diabetes, to see if there are changes. But see, these are testable sorts of things. That people go now, switching gears, people talk about history, evolution, and we're supposed to be carnivores, humans are supposed to be omnivores, and then there's a massively popular omnivores dilemma book that ended up by saying, eat mostly plants. And like, it was not scientific, but it was hugely influential. So, but I've often thought that I want the health of a carnivore, because they don't get diabetes or heart disease, unless they're eating carbs. Is that an appropriate sort of estimation of it?
Yeah, I mean, I think we have to reframe how we define health in many ways. It's just like what does it mean to be healthy? To me, it means I feel good, I function well, I've got all my systems are working as designed for as long as possible. And if you arbitrarily say, well, your kidneys aren't working because your BUN's a little high or your creatinine's a little high, I'm like, well, there's a reason for that. I'm eating a lot of protein, and it doesn't necessarily mean my kidneys are failing. So I think we have to, as physicians, understand what animal we're examining, and I think, again, it's very different to eat the standard processed food, high carb eating couch potato versus someone else. Their labs can be different for different reasons. I think Dave Feldman really put this point: why is the lab elevated? It's not that it's elevated, but why is it elevated? And if we can understand why, we can determine if it's problematic. Like, for instance, I often see people that say, oh, you're on a low carb diet and you have diabetes. Well, you're just masking the symptoms. Your glucose isn't high anymore. Well, explain to me why people are seeing retinopathy reverse. Why are they seeing nephropathy reverse if they're just masking the symptoms? And I've clearly seen, I'm sure you have as well, Eric, it's like, that's not masking symptoms. That's reversal of, obvious objective disease.
Yeah. And that just to echo that, the reversal of the diseases, maybe these are case studies and case series that need to be published, that, short of the Virta Health study, which it's the largest diabetes reversal study today, often people think that you need that very difficult, time-consuming, expensive intervention, when just changing the diet can give you the similar diabetes reversal. The to me, it just seems sort of obvious. Why would I want to have to waste time doing case studies on this? But I'm afraid that's where we are in lifting what we know in the the YouTube world and the internet world into the medical world, or do we need to do that? Do we need to convince doctors about this? I'm questioning
Well,
that.
I don't think we need to convince because most people are changing their. I mean, your grandmother can tell you what to eat. You can pick what your big. All of us are big boys and girls. We can eat whatever the heck we want. And some people look, I see this anecdote and maybe 20 anecdotes that show they're exactly me with the exact same outcome. Maybe I should try that. But I mean, I think it's more the studies I think are necessary for driving policy decisions. And I think the policy decisions can hurt people, school kids, military people, anybody that gets federal dollars, hospitals and so on. So, you go to the hospital, you get poisoned with their junk food, right? So, I mean, it's like crazy. So I think with regard to carnivore, I mean, we've got a case series on IBD that's been published. We have one on anorexia. We've got one on mental health disorders. We've got one on MS that's going to be published soon. We've got another one on psoriasis that's rolling. I'm in the background helping to organize the first interventional trials, which are going to happen. We're probably going to do some interventional trials, carnivore versus diabetes, to start with. So I think, obviously the scientific progression is I have a hypothesis. Let's see if we can observe it. These are the case series. Now let's formally test it. So, I think you have to follow that pattern. No one's going to give you $20 million to study carnivore versus IBD if no one's ever done it before, if it's never been seen before.
Yeah.
It's us being optimistic. Somebody give us 20 million, but it's just like, I do think it's important to do this because there are a lot of physicians out there that are on the fence. They're watching this and like, God, I'd really just wish there was some studies so I can cover my butt. Then I can, because when I was as an orthopedic surgeon, I remember seeing what Tim Noakes went through in South Africa, and I was sitting there like in my noting, I was saying I had a discussion about nutrition with the patient. That's all I didn't document. I put him on a ketogenic diet. I was just like, just discuss nutrition, so that no one could come back and say, aha, you put him on this evil diet. I just said we had discussed nutrition, blah 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 blah, and I didn't go into specifics because I was worried. I was worried that somebody would say, you put this person on a dangerous diet. Which is unfortunate. You shouldn't be in that position. You shouldn't be forced to feel like, you can prescribe a new drug that just got on the market 6 months ago, willy nilly, and there's no like 30-year follow-up. And they're like, well, where's the 30-year follow-up on these carnivore patients? I'm like, where's your 30-year follow-up on the drug you just prescribed? It's not there.
Right. Well, but that's the accepted paradigm that, we just give drugs for things. Yeah, so I'm not sure that doctors are the best target either. And I think the YouTube and grassroots movement folks can learn, like you said, on their own what to eat, and the resolution of problems that doctors can't fix often happens fast. So I guess the issue is how do we get people off the fence to try something like this? What's your strategy to say you should consider it, and here's how you give it a try?
Well, I think that, obviously you've got to, it depends how much time you have to offer these folks. But I think if people have reservations about what are the objections to this, and if you can sort of reasonably assure them that, look, trying something for a month or 90 days, I think 90 days is a better trial. It's very unlikely that some severe untoward thing, I will, as you know, I mean, when you take medically fragile people that are on all kinds of medications and they're trying to do the right thing and maybe fix their lifestyle, that's where a situation where our company like Rivera or another company that does something similar can help to kind of walk them down and taper the meds as appropriately, because coming off medications can be dicey for some people. It can precipitate problems. And so that's something I think you need to have there. I think, one of the things that a lot of patients have experienced is, they get diagnosed with a chronic disease, whatever it might be, diabetes, lupus or something like that. And they'll ask the doctor, why me? Why did this happen? And the doctor usually gives them a very unsatisfying, bad luck, genetics, we don't know, yeah, whatever. That's really unsatisfying for a patient. Then you say, what can I do about it? Well, you're going to have to take this drug for the rest of your life. So now you don't know why it's occurring. The only way you can manage it is depend on someone else. You've got to depend on the doctor writing your prescription, the pharmacy fulfilling it, you having the money to pay for, on and on and on. So now you become dependent and disempowered, right? So you're really disempowered in this whole situation. So when you turn it around and says, we think it's probably because you've been, maybe the lifestyle has been not where it needs to be. Maybe the crappy food you've eaten for 20 years has maybe not been that good for you. We can cut that out. And you can, and there's something you can do about it. That's empowering to people. And I think a lot of people want to take control of their own health. They just don't know what to do. And we kind of outsource our brain and thinking to our doctors, who in many ways, I mean, when you go to a doctor to get healthier, I mean, you can go to the doctor to mitigate a disease and sickness, but to get healthier, doctors really aren't the best place to go in many ways.
At least non-surgeons.
Well,
But there was back to the orthopedic surgery, doctor in Sydney, orthopedic surgeon came and told me that he calculated the back of the napkin, a third of his patients no longer needed the knee replacement when he set up OCAR practice at Tall Knee Autogel. Sure, yeah. Well, and that inflammation reduction is affecting all other parts of the body as well, which, again, yeah, I think the carnivore diet as an elimination diet of all these possible offenders rang true with a recent patient I saw who for 7 years had such bad iron deficiency. She needed, finally, the pills didn't work. She had to get IV iron. And they went to academic clinics and all this, but no one ever really did the perfect test to look for gluten enteropathy in the small intestine. They scoped up, but you can't quite see where the gluten is in the blood test was negative. So, she did carnivore and miraculously is better in a matter of weeks because she cut out the gluten that was causing this problem that was hard for the medical world to diagnose. I'm sure you see this over and over, and so people can bumble on fixing their own gluten enteropathy by doing carnivore, or fixing the dye that's taking away the dye or preservative that's causing the migraine or something. So it's really a remarkable medical tool.
Well, yeah, I mean, I think from the elimination phase, I mean, it really is the ultimate elimination diet, because you're coming down to maybe one food for some people who want to do just a ruminant meat diet, and so if there is a nutritional problem, an irritant or something that you're reacting to, you can solve that problem. When you go on a, like let's say you go on a low FODMAP diet or something. I mean, there's still, when you have you remember that old game Clue? Remember we had Colonel Mustard in the library with the candlestick, right? And you got like 4 or 5 characters, and it takes you like an hour to play through the game. But if you only had one character in one room and one weapon, you'd figure it out real quick. It's like, okay, yeah, it's Colonel Mustard in the candlestick in the library, because that's all that's there. So, it's kind of a nice, easy way to simplify that problem and expedite that, because a lot of people will, it must be dairy, they'll eliminate dairy. Well, maybe it was 3 other things too, and you never took those out. So in that sense, and it's my belief that nutrition impacts every single disease, whether it's acute, whether it's chronic, whether it's genetic, I just see nutrition playing a role in all this stuff. Even in surgical patients that need surgery, the nutrition before, pre, and post is still incredibly important. I would see people that I was telling you, a lot of people were avoiding knee replacements with ketogenic diets, but the patients that I had in the hospital, I would put them on the diet, and their recovery was so much better. I mean, they were like, you know what, Doc, the knee doesn't really hurt. I don't have that much inflammation. I don't have much swelling.
I hear this.
Yeah.
I hear that too from my orthopedic surgeon colleagues who do a lot of referrals to me before pre-surgery. Yeah, so that's great. So, thanks for taking the time to kind of talk through that. Sometimes we get these boogeyman impression of and lampooning of folks, and that actually most of us have gone through either our own personal journey or scientific background to this and want to help people, and that's really why we got into this space. And that rings true so much with your story. And I'm so grateful that you're continuing to do it. May we all be able to continue to do it and also, make a living. Some people think now that that's all, it should all be free. And, that if you're writing a book, you've sold out and all that. I didn't write a book until Walter Willett at Harvard wrote a book. And I thought, well, if he can write a book, then maybe I'm at Duke, I can write a book and I won't lose total credibility. But anyway, any final thoughts on what you would like someone to do in real time, where to find you and what you're doing?
Yeah, I mean, I just think, gosh, I mean, there is so much you can do with regard to your own health, and don't outsource it to other people. I mean, empower yourself, educate yourself. If you need some assistance, obviously our company Rivero, that's what we do. We take people that are medically need help with issues, metabolic disease, autoimmune disease, inflammatory disease, obesity, diabetes, on and on. I'm all over, social media. My social media is kind of goofy because I play a lot. I do some goofy stuff. It's more just to drive engagement so that you can get the real, because this is the real message I have. All the goofy stuff is just, like I said, trying to get enough attention so people see you. And so they'll actually come and listen to what you have to say for real. So I'm, Rivero.com is the company. I'm at Sean Baker MD on YouTube and Facebook, I think. And then my Instagram, Sean Baker 1967. I spell Sean SHAWN, so Sean Baker 1967. And I'm also on, X, S Baker MD, which is the one I started with, the very first one I had. I haven't changed that name. But anyway, Eric, thank you so much for having me on. Keep up the great work you're doing. And I think we're making a difference, man. I really do. I think, compared to where it was, well, you can talk from what it was like 20 some years ago, but it's changed tremendously. And we're clearly making a difference in a lot of people's lives for the better. And despite all the mudslinging and the criticism, just got to keep going forward.
Yeah. Amen. Thanks again. Bye-bye.
All right. Thanks, Eric. Appreciate it. I'll see you next week, I guess, maybe.
Okay. Yeah, that would be great. Take care now.
All right. Bye-bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.